We'll go on to our next speaker. We'll call on Dr. Rashmin Gandhi to talk on diagnosing and managing non-organic vision loss. On to you, Dr. Rashmin.
Thank you so much. Thank you. It's always a great pleasure to be part of these events, which are curated by Dr. Chitra and Dr. Modi. And I'm going to talk about non-organic vision loss. A patient can come to us with problems which may not be related to any known disorders. It can be of efferent system, where he can be talking about total blindness, which can be binocular or monocular, diminished vision, which can again be binocular or monocular, visual field defects or night blindness. There are times where patient can come with a non-organic symptoms of diplopia, voluntary nystagmus, gaze palsy, blepharospasm, hemifacial spasm, and whatnot. We'll be talking only about the visual system problem. So let's start with a person who comes to you with a monocular profound loss of vision. The steps involved would be to have a complete ocular and neurological examination done. Now, if you find at the end of this examination that symptoms are out of proportion to known disease pattern and the science cannot really explain the symptoms, is where we resort to our main meat of our examination, which is pricks and ancillary tests in these patients with non-organic vision loss. So pointers to a non-organic vision loss in somebody who has a unilateral blindness would be absence of RAPD with no ocular cause for loss of vision. We resort to tricks. Basically, we are trying to trick somebody who is trying to trick us. What are the tricks that can be deployed in patient with monocular blindness? Now, you have the trial frame on the patient. You can fog either a good eye by putting a very high-powered +10, +7, +8, or a -7 in front of the good eye, and let the patient believe that he is seeing through the good eye, or also place occluder or a pinhole and keep changing occluder and pinhole in front of the good eye and the bad eye. These movements have to be fast because a lot of these patients keep checking which eye you are testing. So if you can keep doing occluder in front of a good eye and a pinhole in front of the eye where he says that he cannot see anything, quickly keep changing. Sometimes he would be fooled into reading through a pinhole which is in front of the eye in which he says he cannot see anything. Ward-Fodor test or duochrome test, the principle is that you put a red and green glasses in front of the eyes and let him read or see the dots. Now, eye in front of which has a red filter, it can see only the red color, and the green filter can see only the green. So if he's able to see everything, if he's able to read both the lines of duochrome, then we know that the eye which he says he cannot see actually has some vision. Stereopsis, again, is another important pointer towards having a binocular vision. Prisms, there are various ways by which you can use prisms in somebody who has a monocular blindness. It can be a 10 diopter base out prism in front of the non-seeing eye. If the vision loss is non-organic, patient would display a movement towards the apex of the prism. Or you can place an 8 prism diopter in front of the affected eye and ask the patient to activity which requires a good binocular vision, like climbing up or down the stairs. Or a 4 diopter prism held over a non-affected eye and ask the patient to read the lines in the Snellens. Organic monocular vision loss, patient will see only one line, but in a non-organic vision loss, if somebody who has a normal eye, they will be seeing 2 lines. So, and how do you manage somebody who has this kind of monocular profound loss of vision, as it happened in this 10-year-old student who wanted to bunk his exam, and his visual acuity was 2/60, and with no, the examination pointed no obvious pathology. They were counseled, they were given artificial tears, and patient was told that if artificial tears does not treat the problem, then you might just have to give a lot of injectables, and the next vision came 6/6. So that's monocular blindness. What about somebody who says that he cannot see with both the eyes? Bilateral blindness, how would you know that this is more likely to be a non-organic vision loss? Again, pupils will be a good pointer, where a bilateral blindness with sluggishly reactive pupil versus a normal pupil. A normal briskly reacting pupil, generally it can be a retrochiasmal disease, which can be ruled out by doing MRI, And once MRI is normal, you know that in all likelihood, you're looking at a non-organic vision loss in the presence of normal retina. How do you trick this patient? Patient would be able to move in unfamiliar surrounding. There was this very interesting paper by Emery Group, Nancy Newman and group. They said that patients who find this binocular blindness are more likely to be wearing sunglasses while sitting in an OPD. A menace or a bright light or obscene words which will provoke response when you quickly put these in front of the patient's eye. There are tests based on proprioception, like asking patient to touch the nose or connect two fingers, which he should be able to do even in the absence of vision. But these patients would try not to connect the fingers. Ask him to sign, and even patients who are completely blind would be able to make a good signature. Optokinetic nystagmus or mirror test, where optokinetic nystagmus would elicit a response in somebody who has a useful vision. A mirror test where you rotate mirror in front of the patient, and patient would have an nystagmus movement if he has a vision in both the eyes. So that's about binocular profound loss of vision. What about somebody who says that just a blurring, not really blindness? Here, the pointer to would be symptoms which are out of proportion and does not conform to a known pattern. These patients, binocular, blurring of vision, there are Snellen's chart which are available, which you can keep playing around to really trick the patient in reading, which he did not read initially, like changing the distance, changing the size of the optotype. Again, there are these statistical tests, which I have never used, but where you have a patient look at the Landau C, and there is a possibility that patient would choose exactly the opposite direction of Landau C if he is finding the blurring of vision. What about monocular blurring of vision? Pupil again would be a good pointer in this patient, saying that, well, this patient is not likely to have any optic nerve or anterior visual pathway disease. Stereopsis, monocular vertical prism dissociation test, or a fogging would be again a good help to trick these patients. So that's about the vision loss, either monocular, binocular, profound, or mild. What about visual fields? There are patients who may say that they cannot see in the side, but in reality, their visual fields are normal. More often than not, these are the kind of responses that you'll find, especially on Goldman, spiraling of the isopters, crossing isopters, star sept fields, and these patients generally, when you do these either Jerem screening or visual field testing at different distances, they would have tunneling of the visual field except a funneling. In patient with an organic visual field loss, as you move away from the patient, there will be a little expansion of visual field, but the patient with a non-organic visual field loss would continue to have a tunnel vision. This is the example of a typical visual field generally in patient who has a non-organic disease. I would like to highlight, although by presenting a case, this is a 45-year-old female who was seen in 2011. She presented with a gradually progressive loss of vision in both the eyes, and visual acuity was quite poor, like 2/60 in one eye and counting fingers in the other eye. There was no really ocular examination or a neuro-ophthalmic examination, did not really point towards any problem that she might be having. She was married to a type A personality who was very active in politics, and the husband kept saying that she just likes to shut herself in dark room and sulk. She had gone around the town, and a lot of the teams had told her that this is more likely to be a non-organic vision loss. The pointers at that point, when she was first examined, were symptoms out of proportion. She was easily navigating in OPD while waiting hall. I mean, though her vision was poor, was wearing sunglasses. She recognized the optometrist at a 5 or 6 meter distance. So what next? We did MRI brain, we repeated MRI brain orbit, which was normal. ERG, VP, multifocal ERG at that point was normal. So patient was prescribed artificial tears. Next follow-up, a year later, everything was the same, except patient said that she had little more difficulty in bright light than the last year. Again, the electrophysiological test was not really remarkable. Few years later, I mean, during this period, patient's husband had sent me a Facebook friend request, and I accepted it. And few years later, on the Facebook, I saw that the husband has left politics, and now I saw a lot of photograph of the family enjoying and going out of vacation. So I was a little curious because entire history of the patient was blamed on husband being a little more dominating. So we requested her to say, can you come back and see what's going on? So she came back in 2015. Her visual acuity actually was still the same. And husband said that she still just likes to stay in a dark room. Pupils were brisk. At this point, we thought maybe we saw a RAPD. We did the VEP, and VEP actually showed a little bit of reduction in amplitude and on flash VEP. However, now, as you can see here, the ERG had a maximal effect. The ERG waves forms had diminished by now. So here is a patient in her 40s who apparently was having problems which are non-organic, but over a period of 2-3 years now, the ERG started showing a problem. Fundus and MRI was still not very, they were okay. Patient went around a few of the other groups, and then we took an opinion from a retina group, and they thought that maybe patient was suffering from azure. So highlight of this case is that while some of the patient may look like or may even be proven to have a non-organic vision loss, they still need to have a regular follow-up because sometimes they might be harboring something which might become apparent later. So what is azure? I mean, that's what the other team thought, that this patient might be having azure. Generally, it affects women of young to middle-aged. 33% of these patients would continue to have normal examinations, while some of them may show RPE changes or decreased vision. To conclude, while non-organic vision loss is something which sometimes you can be tricked, and patient can now go on internet and see as to what are the signs that they should find. However, these are the organic conditions that are often misdiagnosed as functional vision loss, like pituitary tumors, LHO, and we heard about it from cilia, bilateral retrochiasmal disease, because pupils will be normal in those. Early cone discovery where retina may be normal. Retrobulbar optic neuropathy sometimes can be misdiagnosed as optic neuropathy. However, in these, generally, pupil will be a clue. CAR or MR, and we'll hear about some of these in the next talk, or a small occipital infarct. So in other words, there are ways by which you can conclude or you can diagnose patients with a non-organic vision loss. However, one has to give a maximum benefit of doubt to the patient before we resort to a diagnosis of non-organic vision loss. This is an algorithm which we published in 2014 as somebody who has a functional vision loss. It can be binocular profound process, monocular process, decrease in vision, or a field loss. And we have summarized here as to what are the pointers towards a functional or a non-organic vision loss. I thank you once again for your very kind invitation. Thank you.
Very interesting talk, as always, Dr. Rashmin. It's so enjoyable. How reliable is a visual evoked potential in diagnosing a non-organic vision loss?
So a pattern, so there are two, flash and pattern visual evoked. Now, the pattern VEP, patient can still defocus and can fool the machine, while it is very difficult to have to find flash VEP. So yes, a pattern VEP, sometimes you may get a response which patient is simply not looking at the pattern, and so you may have a waveform which may not be a very good waveform. So flash VEP will give you a very reasonable response, because if somebody who says there's no PL but the waveforms are present, it's likely to be non-organic. Yes, sir.
Yeah, I think it was a wonderful talk, and this is, as we have been always listening, that it is your wits versus the patient's wits. So malingering is like that. Nowadays, because of the Google, I think we have started getting cases which are still more intriguing, like palinopsias and visual snow. I don't know how to deal with them, because sometimes we have no clue. I mean, they say it's there and nothing is anything that we can confirm, because there may be really some visual snow, or it may be just that they have read it on the Google and now they are pretending that way. Or even the palinopsias, I mean, these after images which are prolonged, they keep on complaining, and they go from one doctor to the other, and they're always under stress. So any clues from the panel?
And in fact, before we go to panel, there has been a reverse part as well. If somebody who has a color vision but does not want to fail the color vision test, they just mug up the Ishihara chart because they know that that's what you're going to test on, and they know the sequence. So that's why sometimes you go backward or start from the middle and go back and forth, because otherwise they will try to trick you by knowing what comes next.
Correct. Or they may use a contact lens which is having a red filter.
Thank you.